All right, this is our translational Q&A panel. And translational research is the process of turning basic scientific discoveries into practical applications that directly benefit human health. So we have a range of people on the panel today, from clinicians working directly with patients to scientists working in the lab. So this is an open Q&A panel for you to ask anything. So we're going to open it up for an hour. We have a few online questions that have been pre-submitted, and then people that are joining through Zoom can put their questions in through the chat, and we'll read them aloud. And with that, we'll get started. So just raise your hand if you have a question. Otherwise, we'll start with some of the pre-submitted questions.
All right, one of the online question is, if a PURA child has no history of seizures, is there an age at which the likelihood of developing seizures would decrease?
Hopefully this is on, yeah. So that's a very good question. The truth is, based on our current understanding, probably not. So as I presented in the gene review summary, we know that the age of onset can be very variable from neonatal period. The latest age described in the published literature is 24 years, median age of 3 years. But when we focus in on those individuals aged 18 or older in the published literature, 20 out of 23 are reported to have epilepsy. So I think that there is an accrued risk over time, and this is sort of counter to what we tend to think of with lots of conditions where the older a child gets without seizures, we think the lower the risk might be. But the truth is we don't actually have good natural history data, and this is why we need a registry. But at the moment I would be very cautious, and I would say that there's no specific age at which we think that the risk reduces.
Okay, the next one is, what do you think about the role of magnesium in helping control seizures?
It's a good question. It has been used, or at least attempted to be used. I know you probably would know. But the reality is that it hasn't proven to be that effective, at least. The only place that it might be somewhat effective is in NMDA receptor mediated, where you have gain of function. And even there it hasn't been particularly great. You would agree?
Yeah, I agree. So that's, we have so many seizure medications where we have far better data to support their usage, and magnesium is very little data and very little understanding why that should work in PURA.
Hi, it's Rula from Greece. Okay, I have two questions. My son Vasilis is about to have a surgery, one for his tooth and one for undescending testis, as Dr. Hans said. Is intubation dangerous? Because our neurologist said that because of the seizures and epilepsy, they're afraid to get him there, and the doctor said that we must have a written consent in order to get him in, because after intubation he won't be able to breathe easily, and I would like your opinion how dangerous this is.
So I think an individual risk assessment needs to be made. So what we would normally advise is that the diagnosis is disclosed to the anaesthetist, and that there is a pre-assessment to establish the safety of a general anaesthetic for an individual child. I think it's fair to say that a significant proportion of children with PURA syndrome will have had general anaesthetic. So we can take some reassurance from that in that most children who've undergone general anaesthetic have done so without significant complications, but may need additional pre- and post-operative care and monitoring. But it really is important that the anaesthetist involved makes their own individualized assessment.
I agree completely. Two more things. In our experience, sometimes it's still offered to do an ambulatory anesthesia. That is something what I would not advise to do.
Can you repeat that? How did you, what's the name of what you said?
An ambulatory anesthesia, meaning you go home on that day the anesthesia was done. So that is something we would not advise, but especially because you said teeth and the orchidopexy, those are procedures which are done on ambulatory basis, and that is certainly not a good idea for a child with PURA syndrome to do an ambulatory anesthesia. And the second thing is that the anesthesiologist, as just was said, they have to prepare, they have to look up the syndrome themselves, so they need some time. And therefore, we also advise that you do this anesthesia talk like a week prior at least to the procedure, so that they have time to look it up. As far as I know, there are no anesthesia guidelines or orphananesthesia.eu. There is?
Yes, there is.
Okay. So that would be something they will have to read.
If you go to our website at purasyndrome.org, under published research, there is a link for anesthesia recommendations for patients with PURA syndrome from October 2019. It's linked right on that, okay? Yep. No worries.
I would like to ask about seizures and epilepsy. We have been having PURA for a year. And I don't know if it's helpful or not, because he keeps having seizures. They didn't stop. So I would like to ask, is it a certain type of medicine acceptable for seizures for in every country, or generally you can give what the doctor says and we'll see what happens? It didn't sound as well as I wanted to, but...
No, that's fine. So I think that's a common question. The answer is there is not a one-size-fits-all approach. We definitely don't have good evidence of specific regimes that are likely to work. I think it's fair to say that monotherapy, a single drug, is rarely effective in PURA syndrome, and that most patients who have seizures have quite difficult to manage seizures, and it often requires a cocktail of anti-seizure medications, which are essentially identified through a process of trial and error. What works for this child? Are seizures being controlled? Are we still getting breakthrough seizures? Is there evolution of the seizure type? I think that it's a really, really difficult issue to address. And, we've had numerous pediatric neurologists who've been asked this question over the years, who've been part of these panels, and we don't have a single recommendation that we can say this is what we should be doing for every child with PURA syndrome. It doesn't work like that at the moment, and this is why the work that is being done on an experimental basis is so important. And maybe, Chris, you want to add something on that note?
It's a common question. That was the case for the variant that Ebony had. We now have a framework. I'm really hopeful that we can do something similar, but it is a mouse, so we have to recognise that, one, and ultimately the only thing that really matters is if it helps the children with PURA, and that's only going to ever be found out in a clinical context. So a bit of a way to go, but again, hopefully the work that we're doing will help identify, at least maybe, even just knowing what you shouldn't give is as important as what can be given.
Hello, I'm Cordula from Germany. Hello. We did talk a lot about seizures and muscle tone and walking and movement with these children, but I also would be interested in social emotional behavior, which is very often and common, because I struggle a lot with my son's problem. How far is it worth fighting and trying him to learn follow certain, how do you say it in English, rules and stuff in school, whatever? Is he able to learn? Is it him just being naughty, or is it related to PURA, which might change the way of treating him?
Okay, so what I would say to that is that probably nobody on this panel is well placed to answer that question. That is definitely something that you'll get a better response from the parent community as a whole. You have the lived experience. It's a collective experience, and you know what sort of things have worked for you and what hasn't. Again, every child is unique. But I think that as clinicians and scientists, this is one of the questions that we're really not actually very good at answering at all.
Well, that is truly one of the questions what we are faced in our specialty clinic every day with. And I mean, honestly, that has to be a longer talk to actually hear how old is your child and where is he cognitively and what are the things he can do well. Hey. And what are his difficulties? Because these cooperation problems and as all behavioral topics, we usually say that we can expect a behavior from a child as it is associated with his cognitive age. So therefore we have to look first at the cognition, where is he at his cognitive level, and then we would expect a behavior based on that. Like concentration is a very common issue. Of course, if a child has a cognitive age of 3 to 4 years, then I cannot expect that the child sits 45 minutes long in the school, right? And another thing is also very commonly the speech understanding and the ability to communicate the child itself, which also leads to a lot of cooperation problems.
Okay, thank you.
Perhaps I can add, when I get it right, the Australian Foundation is supporting research to investigate exactly that. So I would hope that soon we'll hear more about that. Tomorrow.
I just had a comment on the KEPRA issue to relate. Our child was put on KEPRA about a year or so ago, 2 years ago maybe, and his personality totally changed while he was on that drug. He stopped playing, he stopped interacting, he was sad. It was very sad to see him like that. So, and he slept most of the time. So we took him off of that and put him on Briviact, which is the same kind of class, but a little bit less side effects. But he still didn't return to himself. So we finally just took him off of that, put him back on rafinamide, and he's almost back to his baseline level. It's good to see him happy and smiling and interacting again. So I just wanted to relay that to everybody.
So I'm piggybacking on you, Mina, is that my son was put on Keppra last year, and we've had to increase it a little bit, but he has been completely seizure-free this year and has had no change in his personality. So it just is to show that everyone is very different. Okay, so who's next? I do have one online.
Hi. From the from the doctor point of view, when we go to the neuropediatrics to have some controls, do you have some recommendations on EEGs? I know that there are a lot of PURA kids that have epilepsy, but it doesn't show on EEG. But in case we can increase the chance of catching them on EEG, do you have some guidelines? So we have EEGs every 3-4 months when he's awake and 10 minutes. So this is what our doctor is doing. So I would appreciate if you have any recommendation from your experiences.
You say so. So the serial EEGs is something what we actually don't do anymore. We do rather EEGs if something happens, if the parents tells us something, then something is different, and there are any kind of movements which could be of epilepsy, or the sleeping is getting worse, or stuff like that. And if we do EEGs, we always try to do also in sleep, because it's a nice thing to know the EEG, but actually for me the question is always, do I have to do something, right? And to do studies or diagnostics without any effect on what we do at the end of the day is actually just time consuming for everyone. So therefore, if the child doesn't show anything, then, and any symptoms, which could be an epilepsy, we don't do serial epilepsies. If the child shows something, we also do it in sleep, because there is also a sort of epilepsy where you only see the spikes in sleep, and they sometimes have to be also treated.
So I should say I'm clearly not a pediatric neurologist, but it might be helpful to keep an event log with a description of the events. Try to capture a recording on your phone. So I don't know how it works in other countries, but in the UK, most hospitals have a facility for receiving footage of suspected seizures and reviewing those and deciding whether any action needs to be taken or not. Obviously, if you keep that sort of event log, it may become clear when these episodes are happening, whether there are any triggers, and that might inform a decision about video telemetry, for example, an admission with a prolonged recording of brain activity plus video footage to see what the clinical association is. And of course, there can be effectively ambulatory EEGs as prolonged recordings as well, provided those are going to be tolerated. But I think it makes sense to talk to your child's pediatric neurologist about your concerns and to try and share more information with them so that they can make an informed decision.
So here I am. So given that the clinical pictures of children with PURA are so different, and now we have heard the specific situation that one medicine gave two totally different reactions. First of all, how do you explain that there are so many different clinical pictures, so various? And secondly, how much it makes your research and your conclusions to be difficult, and how can you at the end, since I'm not a scientist, I don't know how you do that, so how at the end of the day you can draw some conclusion and say, well, this is it, this works, you know, or doesn't work? Thank you.
Yeah, I mean, it's a very valid question. Is that working? Yeah. It's a very valid question. I think the example I gave you, we know that valproate, for example, works very, very well in some patients and doesn't in others. What we do know is that lamotrigine invariably has caused quite significant seizures. So I think what we're going to try and achieve is to create a framework. And I don't think we're going to get away from the trial and error at some point. What we want to do is get as many children on the right drugs as early as we can. And that's what I'm hoping that we can achieve, because we are going to have this individuality. There's no way around that, I don't think. To your question as to why things work differently, I mean, what you were talking about there was more of a side effect impact, really, you know, in terms of not necessarily around impact. And, you know, we're all very different. We have a very different genetic makeup, and some people respond to drugs very differently. So that's not going to go away. And that comes back to the point where, you know, your children are individuals and they're going to have to be treated as individuals. But we've got to do better than the trial and error, 20 drugs, you know, cycling through that's happening currently. And I guess that's our hope, that we can achieve that.
Perhaps can add. Another entry to that question is, entry point is to use patient cells from different patients, and then do, for instance, these organoids we do, and see what is common between those, and of course what is different. And the commonalities are much easier to get, right? The big thing would be if we could really connect the differences to different behavior or responses to drugs or so. I mean, that's really a long shot. I'm not sure if we ever manage that, but in theory, that is the right approach, or one of the right approaches towards that.
I should add one thing, ultimately precision-based therapies, by definition, if you're fixing the broken function, it's hard to imagine that not working across the board. That's probably where we need to be getting to in precision medicine, that this is the mechanism that's causing seizures, this is what we need to target. And that's not going to be trivial in PURA, I think we've already heard that. But that is something to bear in mind, that precision medicine should work across the board.
And I'll just also add from the genetic standpoint, so today we've obviously spent a lot of time focusing in on the PURA gene and rare variants in that gene that obviously cause PURA syndrome, but patients with PURA syndrome also have variants in other genes, and we know now from studies looking at what we call polygenic risk, so we can look at multiple variants, not in the PURA gene but in other genes that we all carry, and it turns out that some people will be more susceptible to a seizure than others just based on their genetic background. So, and that sort of information isn't yet being used clinically, but the research is being done to look at which genes might be important for a given phenotype like seizures, with the hope that not too long in the future we'll be able to assess the risk of common variants in other genes on the background of a rare variant that causes a syndrome like PURA. So I think there's progress to come in that, and that will probably explain some of the complexity that we see in patients with PURA syndrome.
Seems to be a topic we all like. And this is why the blood samples are so important. So if you give blood, because that gives us a gene expression profile of you. The great challenge here is that it's a rare disease, so it's very difficult to get enough transcriptomes, as we call them, to really do this analysis, because in particular when you, and this is something where you could say, oh, throw AI on it, right? But you need a lot of data points for AI and to model these things. But that's another hope, that we could get information from those blood samples. So that's why we're also so grateful that you've been so proactive in donating.
One, two. Oh, you can hear me, right? I would like to ask a question about genetics. Question is the following. Currently, when you are watching news in genetic publications, personally I track few websites with, let's say, breakthroughs in this area. There are so many approaches which could or could not work if we're talking about genetic therapists. And my question would be the following. Currently there are breakthroughs in CRISP, Cas, in prime editors, base editors. As far as I get, it's very different approaches in same area, as well as actual delivery. Delivery is another challenge, and depending on particular, let's say, genetic syndrome, delivery approaches varies a lot. And question would be particular to PURA. I try to research myself what the most, let's say, suitable approaches which can be applicable for PURA syndrome in terms of actual genetic correction approach and delivery approaches. And if we're talking about version of PURA where there is a just genetic change in gene itself, not like full deletion of the gene. From your point of view, what makes sense to me as a PURA parent, makes sense to track news, which approaches make sense or potentially could make sense in terms of correction, and what potential approaches could be applicable in terms of delivery. So maybe just for me, what makes sense to track. Basically, sorry, I have very basic understanding. I just reading papers, So, but it would be great if you can share your insights, and if you think it makes sense, would be great to very, very high level explanation why it makes sense for PURA. But if it's too much, we can skip why part.
Perhaps I can start because this is really a very complex topic, yeah, you get the news all over the place, how there's one success after the other. Most of those things are happening by using, correcting the cells outside of the body. So disorders, that are happening in the blood, or metabolic things where you can, where it's enough to change, for instance, correct a gene in the liver, and then the whole body feels better. We have the big problem that in the brain, PURA is not there in sufficient amounts. And at least to the best of my knowledge, there's not an efficient and safe approach to do that in brains. There's lots of claims that this might happen, but today, no, not. And when you also look at the drugs, there are the first CRISPR-Cas drugs FDA approved now on the market since I think last year. One of the risks that are mentioned to the patients to be considered is cancer. And there we are at the point where you as a parent have to balance between the risk of such a treatment, as good as it sounds, and the potential harm you do to your kids. And you don't have a neurodegenerative disorder where, for instance, one brain cell after the other dies and your kids get worse and worse, and the kid will die in the end. It's not the case. I mean, your kids are disabled, but they're happy kids and so on. I mean, of course, epilepsy is a difficult thing, but all over, when you assess it from distance, I think the risk profile is not really in favor of such therapies that are really explorative and experimental, in particular when we talk about brain. And when we talk about the gene vectors or the shuttles that bring, for instance, CRISPR-Cas into the body, we do have repeatedly and still deaths of people from clinical trials with these AAVs, adenovirus-associated viruses, which is the favorite model because of viral overload and so on. And those patients sometimes have multi-organ failures and so on. So this is dramatic, and it's something that has not been resolved. So also from this, there's a significant risk coming. We would love to have something that does it. And there are serotypes, for instance, of AAV that are neurotrophic. That means they really go for, they're like neurons. So that's a step in the right direction, but still there's a considerable risk to be taken care of that. And I think that's a good motivation to look for other ways, and understanding how the symptoms occur, and also by knowing that most of the wrong wiring has probably happened before birth. Controlling the symptoms and reducing the symptoms by understanding the mechanisms behind that seems to be much, much safer and perhaps also easier and faster to achieve. Yeah, it was part of, I think, my master course lecture. Sorry.
I wanted to say just also a word to that. So a gene therapy is nothing what you can do like a drug repurposing approach in a clinical, regular daily care, right? So that would be a clinical study, that would be an approval, a phase 1, a phase 2, a phase 3 study. That is nothing what you won't notice. Especially you have here a PURA Foundation with an own website, a lot of people looking into that. So I would like to encourage you to, of course, you read about the disease of your child, and because you are interested, but I don't think that you have to be afraid that you don't notice if there is a new therapy coming up.
Okay, we're going to do one from online. Our son was diagnosed with bilateral hip dysplasia in early childhood. At that time, we were told that his hip joints had not developed properly. However, this year, at the age of 16, new imaging showed that both hip joints appear to have developed normally, despite him never having had any surgery, bracing, or other orthopedic intervention. Is spontaneous improvement or late development of the hip joints possible in individuals with PURA syndrome, or could there be another explanation for this finding? Have you encountered similar cases in your clinical experience or research?
So the short answer is no, I'm not aware of similar cases. So hip dysplasia is probably underdiagnosed in PURA syndrome. It's not necessarily present in infancy. It can be of later onset. I'm not aware of any instances of spontaneous resolution, so I think there would have to be a question about the original diagnosis, so you might want to get a specialist to go back and review the imaging and how that diagnosis was made. But if there's been recent detailed imaging that shows normal anatomy, then I suspect that the original diagnosis may not have been correct. But I personally am not aware of any cases of spontaneous resolution.
Okay, I'm going to do another online and then we can do another in person.
What? Oh, sorry, go ahead. I just wanted to say, so this hip dysplasia is very common in patients with neurodevelopmental disorders. It's not just something PURA specific, and the more muscle hypertonia is there, the more patients have this secondary hip dysplasia. And it has usually not something to do with the bone structure itself, but it is due to this yeah, the power which is on the hip, the tension forces. Thank you. Well, so it's physics. Yeah. So, and of course, every hip joint is developing as the child is growing, and the question is it developing in a normal way because there is normal tension on the hip joint because the child is developing normally, motorically, or is it an abnormal development? And for us, I completely agree, it is underdiagnosed. That is something we are very keen on to find because from the operational point of view, there are two different operational possibilities. One is eine Schraube. A screw, yeah, hip screw, yeah. This is which is a short operation, and it stabilizes the hip so that it can grow forward in a more balanced way. And the big surgery is a complete new hip joint, yeah. So we want to find the secondary hip dysplasia early to be able to offer the short and quick operation for these patients.
Okay, any research or work on PURA and aspiration or dysphagia? Any insight on improvements or regressions over time?
I'm Mia, for those who don't know me, and I'm speaking tomorrow on communication, but we also have part of our study where we looked at dysphagia and feeding. So I won't present on that tomorrow, but that's something to come, is some information about feeding in our population. But longitudinally, we don't have data on that. It's at one time point. But others might have more to say, sorry.
I mean, feed disorders is one of the most common problems, while young children, when like few-month-old children, when you don't see so clearly the developmental delay, come and get a genetic diagnosis because they just don't feed well. And it's fairly similar to the hip dysplasia question. The more muscle hypertonia, the more difficult to feed the infants at this age. But that has not necessarily has to do something with the dysphagia, because that is another control. And therefore, I mean, I don't know about any studies, maybe because there is none, but there are experts on these feeding topics in every country, and that it's a very good idea to go to these experts, especially in this early phase, because the way of treating can be very different for the patients.
Okay, so me again. I've managed to speak yesterday shortly with Professor Niesing, and he mentioned that, if I understood you correctly, please correct me if I'm wrong, that actually the wrong PURA protein is not necessarily doing the wrong thing, and it may be that the fact that there is not enough of healthy PURA proteins that are causing the effects that we can see with our children. So are there researches that are working on enhancing of production of more healthy PURA proteins? And if this would, at the end of the day, happen, that there could be more healthy PURA proteins in the cells of our children, would that mean that at that moment the overall situation with our children would improve? Would they be able to reach what they lost in the meantime, and what we could expect of it? I know it's hypothetical, and I know you don't, and you know that I'm not expecting you to give me a firm answer. But you know, what could happen, or what could happen in case this happens?
So I think so far there's no good indication that the wrong copy, in the most of the cases, does something harmful. So this would be dominant negative, as we call it. But there might be individual mutations that have such an effect. I think people look into this, but there is no firm evidence for that. So I think for now, the idea that half of the amount of PURA is not enough and this causes the symptoms, this is the by far most likely scenario. So this is why we go with this. And this is why also the idea to upregulate PURA is the obvious answer. And for sure there is research on that, definitely. But I don't think that there is any solid results on that. And it's really difficult to speculate. As I showed earlier, with the potential impact, I think it is very, very unlikely that you would restore, even if you would do a full genetic restoration, right? So genetically you would correct everything. What you define as a cure is, of course, that the your child looks and behaves like a normal, healthy child. And I think this is really unlikely. We have no idea, I think, what we can expect in terms of therapeutic window. So what in terms of improvement is possible, because nobody has done it for PURA. But I think for other disorders, there might be some ideas, and then perhaps somebody else could say something about it. This is wild speculation.
Yeah, it's very speculative, so you really have to look into the details if we talk about gene therapy, and therefore it's very difficult to say them. There are gene therapeutic approaches which are working well. They are not for all patients, so like, for example, we have patients with Alexander syndrome. She got into the clinical trial with gene therapy, and she's doing excellent. But we have other patients with leukodystrophy who didn't get treated because they were in some exclusion criteria. So it's difficult to say. And also those who did receive, like, for example, this Alexander disease, there was a gene therapy trial. Some benefited and some did not.
Are the two overexpression studies that are going on relevant to this question?
So only in the sense that we have reason to believe that the dosage of the PURA gene is important. So too much of the PURA gene could be detrimental. It doesn't cause PURA syndrome, it causes other issues, but that is a key consideration, and it's an important consideration in terms of gene therapy. So the dose of PURA within an individual cell needs to be very carefully titrated, and that's difficult to achieve.
And just to add to that, I mean, I don't think there's evidence that for proteins like PURA that obviously have a function in controlling expression of many other genes, I don't think there's evidence of a successful replacement strategy. Most of the successful examples are enzyme replacement strategies, where our cells have strong systems in place to regulate the amount of enzyme, and I don't think we yet understand how the levels of transcription factors could be much lower, and we don't understand how they're regulated. So that the challenge would be that by increasing the level of the transcription factor too much, you might have adverse consequences, as we might see with patients that have duplications.
And obviously a shout out for the animal models, not just ours, but the Jackson labs. We can test those ideas, right? Certainly the toxicity along those lines. So the ecosystem's here to work it out before we get to anywhere near the children.
Hello. I would like to ask if PURA is hereditary, and if our other children need to take some kind of test when they grow up and they want to start a family.
Okay, in short, in most cases, PURA syndrome arises due to a new genetic change which has occurred in the affected child. So it will be either the egg cell or sperm cell, but we believe most likely the sperm cell that has those two things coming together to make an embryo. So that genetic change is present at conception. However, in most cases, we believe that parents will not be carriers of that genetic change, and when we test their blood, we find that they are not carriers. However, as Michael explained earlier in his presentation, there are states in which a parent may carry a genetic change in just some of the tissues of their body, which is called somatic mosaicism, and sometimes that's detectable in blood at very low levels. But there's a specific phenomenon known as parental gonadal mosaicism, which is when a parent carries the genetic change in a cluster of cells within their reproductive organs. And of course, the tests that we do on parents are blood tests. So we're using DNA from blood, and we're making an assumption that it's representative of that person as a whole. And we know empirically that that is not always correct. And our generic risk that we would say to any family that has a child with what appears to be a de novo condition is that there's a less than 1% chance that in a following pregnancy, a child could be affected by exactly the same genetic change, and that being due to this phenomenon of parental gonadal mosaicism, which we can't easily test for. However, what we do know is that there have been some publications over the past year or two showing that the rate of mutation within the PURA gene is statistically higher than what we might normally expect for the size of the gene. And the speculation is that there is what's called a spermatogonial advantage. So in the male, if this happens in a cluster of cells within the testes, it might actually confer an advantage in terms of producing sperm. So the risk may be slightly higher than what we think of less than 1%, but it's not going to be phenomenally high. But this is research which is still ongoing. But essentially, if both parents test negative, as we would expect them to, we would say the risk of another child having that same genetic change is going to be very low. And ultimately, if a child is completely developmentally normal, then you can be completely reassured that they do not have PURA syndrome, in the sense that we would expect that if there were two siblings who were affected by PURA syndrome, that they would be clinically manifest, in that it would be obvious to you that they are affected. Obviously, Michael talked about mild cases of PURA syndrome, but still, these are individuals who clinically have signs of being affected. It is a fully penetrant condition as we understand it. So we don't believe there are any people out there who have disease-causing changes in this gene who are not manifesting clinically and having signs to go with it. I don't know if that answers your question. Yeah, sorry, I've rambled. I'm sorry.
Follow-up for exactly this question. In most of the, let's say, articles, it's stated it's not for PURA, but in general, if a syndrome is de novo, usually you could expect like less than 1% of risk for second child. But I would challenge another thing. Like you stated, usually with the parents doing just blood test analysis, and it cannot prove that you don't have this, sorry, what's the term, so when mutation could be from your cells, like sperm, or if it's woman cell, I forgot how it's in English. Yeah, and as far as I get, obviously there is not well spread tests that you can check if you actually don't have this mosaicism in your cells, right? And if to assume if you have it, risk is very, very different. It's not less 1%, it's much higher. But in order to prove or disprove it, you need to do a test, exact test just for it as a parent. And problem, as far as I get, there is no test for it because it's super hard to test. That's how I get it.
Yes, I mean, to be absolutely confident that a parent didn't have gonadal mosaicism, you would have to test the whole of their reproductive organs, which would render them infertile. So, it wouldn't be feasible. So in males, it's slightly different because we believe that the genetic changes are more likely to be paternal in origin. So there are research-based tests where, for example, you could take a sperm sample from a father who has a child with PURA syndrome to see whether that same genetic change could be detected in sperm, and that could be a useful test. So for males, potentially, yes, you can do the test. For females, it's far harder, but ultimately, that is an empirical risk. And yes, if it is present, and if you go on to have a second child who is affected by exactly the same genetic change, you can say definitively that that parent is gonadal mosaic and that the risk for future pregnancies could be as high as 50%. Yeah, absolutely.
And just from the practical point of view, so in Germany, if you have a child affected with PURA syndrome in every pregnancy following, the insurance is going to pay for a prenatal diagnostic. And also, I wanted to say one more thing to the last question. In my experience, some adults who have grown up with a child with a neurodevelopmental disorder just want to see it black and white, that I'm not carrier, even if all chances say that they cannot have it because they are healthy. And we are talking about a disorder where everyone has symptoms who is carrying a pathogenic or likely pathogenic variant, and still sometimes they still go and they want to have the paper that I'm not carrier. And I think from the psychological point of view, that might be also okay, and it might be a good idea to have it if then you have a better feeling about planning your own family.
I suppose the only other thing that I would say is that because the empirical risk is low, if as a couple you had a high level of anxiety about recurrence, probably the most pragmatic thing to consider would be non-invasive prenatal diagnosis, so where a maternal sample is taken, blood sample, during pregnancy to test to see whether that exact genetic change is present. In most countries, that would only be available as a private test, but it is something which is available, and it's something that you should talk to your local clinical genetics service about if there is a high level of anxiety about recurrence in a future pregnancy. I don't know if that's helpful.
Hello, that's a question from one of the parents that send it to us. So regarding the ophthalmological problems, is there only symptomatic treatment of them or something more specific recommended for the PURA patients regarding that the vision problem might come from the either hypotonia of the muscle system around the eyes, or because it's more related to the epileptic symptoms. So is there any change in the just symptomatic treatment of the ophthalmological problems for the PURA syndrome?
So at the moment, no. I think eye health is a big thing in PURA syndrome, so I would recommend that all children with this diagnosis have a formal assessment by their local ophthalmology department, including orthoptics. If you have access to electrodiagnostic testing as well, then that can be useful to look at things like VEPs. But ultimately, to my knowledge, there isn't any sort of bespoke management for PURA syndrome. I think we know that there are different types of problems that can happen in terms of vision and eye health. And so the individual needs to be assessed and managed according to any manifestations that are identified.
Okay, we have a couple questions online. We need to wrap it up because we're almost at time. So one person has 3 questions, but there's one about AAC, which I think we'll save for tomorrow because we have our communication presentation tomorrow. So we'll start with this one and then one more. I saw data showing that 87% of PURA patients under the age of 18 have epilepsy. Does this mean that my daughter is likely to develop epilepsy later? Is there a relationship between age and the onset of epilepsy and PURA syndrome? Is there any things that doctors can do to prevent epilepsy before it develops? And also, if epilepsy does occur, do the medications used to treat it affect or limit a child's neurological or brain development?
So I think we've probably touched on most of that earlier, so I won't repeat everything that I said on one of the earlier questions, but ultimately the key thing is that we don't have the natural history data at the moment. There could be some form of ascertainment bias in this group of patients. We know that in the past, one of the ways that PURA syndrome was identified was through epilepsy gene panels. So it could be that adults who've got difficult seizures who have had those diagnoses made through epilepsy-specific panels, and therefore there is an ascertainment bias. We need to follow individuals from birth through to adulthood to see what the rate of accrual of seizures is as life progresses. And only then can we truly answer this question. So I would be cautious in interpreting the gene reviews data. We've taken it as a crude figure, just looking at those individuals in the literature. But the question is, how did they end up in the literature? How did they end up with their diagnoses? Because if they were identified through epilepsy gene panels, then there is ascertainment bias there. There could be many other adults of a similar age who don't have seizures, and it could be closer to 50%, as it would suggest is the rate of seizures across the whole of those published patients. I think there's a lot of uncertainty, and I would just come back to this point of we really do need good registry data, and I'm hoping that the new registry will deliver.
Okay, and one last question here. If the major pathology were established before birth through altered neuronal differentiation, what are your thoughts on the evidence that PURA has important postnatal roles in synaptic development and plasticity?
I can start. I think this is essentially what I tried to convey in my talk, that there's a very low risk of, curing. I think it's with all, realistic assessment that does not seem to be reachable, but development, of course, of the brain continues. And of course, we can just anticipate that PURA does play a role later on. And if you add enough, the correct amount, this is important, then this will have a beneficial effect, and perhaps the developmental delay is perhaps reduced slightly or strongly. We don't know. We have no idea how much that could benefit, but yes, for sure, this is a very realistic scenario. And this is also why I had on my talk the hopeful green on one of the slides. You know, this is the window of opportunity we have, and that's what we work on, I think.
I'd agree with that. You know, again, the mouse modelling is going to give us an opportunity to look at the different developmental time points. If we have a genetic therapy that works, it'll give us indication of toxicity, it'll give us indication of whether it's efficacious or not. And certainly the gene therapies that have been targeted at ion channels, there's no doubt that they're improving developmental outcomes. So it's not just the seizures that are improving, but a lot of the other symptoms. So there is hope, but it has to be couched with the fact that PURA is there very early.
All right, we are going to have to wrap up our Q&A portion. Thank you very much to our panelists. We appreciate you. Oh, we have one more question, sorry.
Can everybody do that again?
Thank you.
I'll give it to Mel to put on the website.
What do you think about RNA therapy and PURA syndrome?
So there are different types of RNA-based therapy.
But who is the best?
We don't know what works. I mean, I think you have to really explore it specifically for PURA. And again, this comes back to the question, do you take shortcuts and say, you know, I just go for what works in other disorders and then, you know, you hope and put all your money into that? Or do you explore the different mechanisms? Because it always comes down to regulatory mechanisms. How can we regulate the PURA gene in a way that, you know, it fits with the therapeutic goal? And that is, first of all, basic research. For a long time, I don't want to say what I mean with long, because we don't know. But then once we understand, I think we have a reasonable way to hopefully approach that. If this would work in patients, we don't know. But one thing about the RNA-based therapies is, in contrast to gene therapy, that it is meant not to be permanent. For instance, we have this spinal muscular atrophy, Spinraza. That's an ASO, antisense oligonucleotide-based therapy, had dramatically positive effects, but this has to be given every couple of months into the spinal fluid with a certain amount of risk associated with that. So, you know, that's also not a safe harbor, but it could be, of course, one of the possibilities, yeah.
Okay, thank you.